Our association is the product of some nice and fruitful discussions some of the founding members of the Cyprus Association had for years, but for sure the need for a professional society in the field of public health in Cyprus became obvious during the COVID-19 pandemic. It is thus a great pleasure that our aspiration materialized and the association was officially established in February 2022, following a relatively long formal procedure that is required by the Cypriot law. Our vision is to improve public health practice and research in the Republic of Cyprus, to advance the well-being of all people residing on the island, and to narrow health inequalities in our society. What is our mission? To support our members so as to collectively achieve this vision. And how can we do that? By promoting and supporting all the basic public health domains at all levels, from education of professionals and the public to community engagement to infrastructure and policy. We hope that we will successfully serve this vision and eventually achieve our goals, but this requires your support and membership as well. Over the next days, we will announce the details of how to join CyEPHA and the benefits of the membership. I would like also to mention that it was a great achievement that the first interim board, namely Nikos Mitleton, Urania Kolokotroni, Adri Panagiotou, Dimitris Lamnisos, Alexandros Iraklidis, Christiana Kuta, and me managed to organize on time, despite the hard deadlines, this event in the context of the Public Health Week. And not only that, perhaps our greatest pleasure is that our association, very soon after its establishment, was welcomed by the European family of public health professionals. CyEPHA joined EUPHA, the European Public Health Association, which is the umbrella entity that embraces national public health associations across Europe and essentially networks thousands of people who work in the public health domain. And of course, we are very happy that the executive director of EUPHA, Dr. Dineke Ziges-Padget, a widely recognized person in the field of human rights and HIV/AIDS, honors our event with her presence. Once again, I would like to thank all of you for being here with us today, virtually for this event, but we hope physically the next time. And I would like now to invite Dr. Dineke Ziges-Padget to address the meeting.
Dineke is muted.
Dr. Padget, can you hear us?
Yes, very good. Now it's working. Yes, I couldn't unmute myself. I apologize for that. It's really an honor to be here at this event organized by the new EUPHA member, the Cypriotic Epidemiology and Public Health Association. We at EUPHA were surprised at the speed of how you organized setting up the association, becoming a member in March of EUPHA, and then straight away being very active in the European Public Health Week. I mean, it really shows an enthusiasm towards European collaboration and also visibility for your association at European level. As George has already said, we are a European Public Health Association, so an umbrella association for national public health associations throughout Europe. And at the moment, we have about 18 members from 34 different countries. So we're slowly moving forward. One of the initiatives we took is this European Public Health Week, which is aimed at looking for collaboration, not just at European level, but at local level and at regional level as well, working together, showcasing European public health or public health to the audiences in Europe. Another thing we're organizing, and obviously I look forward to meeting you in person there if all goes well, is our European Public Health Conference, which is organized this year in Berlin from 9th to 12th of November. So it would be great if you could come because we're celebrating 30 years of EUPHA already. So I look forward to that. But I don't want to take too much time because I'm really looking forward to the discussion. So I'll leave it at that and hand over. Thank you.
Thank you very much, Udine. Again, it's as George said, it's an honor for us to have you here today at this event, and you have always been very supportive to us during the development of the association. You have welcomed us to the European family, and we are very grateful for all your support that you have been providing all this time. So thank you once again. Now, moving on to the guest, to our guest today for the guest presentation, Jessica Nihlén Fahlquist. I hope I pronounced it the Swedish way. So Jessica is an associate professor of practical philosophy and senior lecturer in biomedical ethics at the Center of Research Ethics and Bioethics at Uppsala University. She is responsible for ethics education of medical students and also students in basic sciences at Uppsala University. Jessica's research work is in the area of public health ethics and specifically on the role of moral responsibility, both at the level of the individual, but also at the level of governments and organizations in reducing public health risks. She has very recently published on the role of moral responsibility of governments and individuals in the context of the COVID-19 pandemic. And this is what has made us ask her to come and join us today and give her a presentation on the public health risks and moral responsibility in the case of coronavirus pandemic, which is obviously a very current topic. So Jessica, thank you very much for accepting our invitation, and we're looking forward to listening to your presentations and your thoughts on the topic. Thank you once again.
Thank you. Thank you, Irene, and thank you so much for inviting me to this event. I'm honored, and also congratulations to the new association. So let's see if I can share my screen. Yeah, it worked just like that. Yes, so as Irene said, my focus is public health ethics, my research focus. And especially moral responsibility. I've also worked on risk ethics, which is a new area, relatively new area, and also ethics of technological risks and environmental risks. So there are some features that are common and some features that are different between these areas. So in order to discuss moral responsibility and public health in the coronavirus pandemic, there are certain steps that we have to take. So first, I think, because we're in different fields, I think we have to talk about public health ethics generally first. What is that and why do we need it? In order to discuss public health ethically, we also need to have some knowledge of the ethical theories and perspectives, the competing, you could say, perspectives on what is right and wrong. It's related to the ethics of risk, as I said, and moral responsibility is a complex notion and concept in itself. So we need to talk about that too. And then, of course, the coronavirus pandemic is the case to be discussed from this perspective. And I think it's so interesting during the horrible pandemic that one thing that became clear is that there are ethical aspects of public health. And I think it was clear to experts and media and also the public. I think it became clear that there are ethical aspects to discuss and not just scientific evidence-based aspects. So let's start with the public health then. Why do we need to discuss it ethically? It's a good thing, right? It's there's an assumption that public health is inherently good, if you will, and that we are always doing the right thing if we're promoting health. And in a sense, of course, it is. It's a great thing that we have public health and that EUPHA has existed for 30 years, which is amazing, and that you have this, and that we all want to do good when we're working in public health. But there are, of course, as you are aware of, I'm sure, unethical examples in history, both in public health research, but also public health policy and interventions. We had compulsory sterilization in Sweden and other countries as well. We had several examples in Tuskegee, for instance, where research was done on African-American males without consent and without treatment, trying to find out how untreated syphilis would develop. So we have really, and of course the Nazi experiments and whatnot. So it's research, but also how that research was used in society, which is why we have laws and ethical standards, etc. now. But it also means that, you know, we can look at these things as bad apples, or in a historical context, saying that the norms and values were different then and now we know better. But I think, as always, we need to see this as we have to keep this in mind, that public health can be used for good and bad, and there are always ethical aspects that we need to stop and reflect and discuss before we move on, especially in contexts where the aims are good. We want to do good, but then we have to reflect on how we do good, why, and what are the effects. And of course, as you're all working in this field, we are dealing with or aiming to prevent disease and promote health. And interestingly, from an ethical perspective, what I find really interesting is the difference between regular healthcare. As Orania said, I teach medical ethics at the MD program. So medical ethics is one thing, regular healthcare, patient-doctor situations. Public health is, of course, different because it's aiming at the health of the population. So it's the different levels of, and the ethical questions are slightly different in these areas. Of course, there are different ways of promoting health, legislation, incentives, nudging, of course, information and communication. But all of these measures and strategies and policies entail ethical questions and challenges and affect our values in different ways. And this is apparent if you look at the coronavirus risk management strategies that were used. So we had different strategies and policies and ways of managing this in different countries. Devar has described this as three main categories of risk management strategies: laissez-faire with few, if any, measures; herd immunity with voluntary measures primarily; and aggressive measures with stringent interventions, lockdowns, limitations of civil rights to a greater extent. And I think this is what is interesting, that we see now that although we have the same evidence, the same scientific information, different countries still chose different strategies. But we all wanted to prevent the pandemic from developing as it did. We wanted to minimize deaths and prevent the spread. But we chose different strategies, and the different strategies involve different values. And this becomes obvious if you look at the different strategies, that it's about ethics as well as science. As an ethicist, you can look at these strategies from the perspective of ethical theories. So ethical theories discuss what is or analyze how you should make decisions that are right, how to act and decide in an ethically right way, or make sure that the right thing is done. And we have different main categories of ethical theories: consequentialism, primarily utilitarianism; deontological ethics that deal with duties and rights; and virtue ethics that focus on character traits and habits. And of course, there are many different versions of these theories, and you don't need to know maybe you already have knowledge of this, or you don't, and you don't have to memorize all the details, of course. But the main difference is that consequentialism and primarily utilitarianism, which is a consequentialist theory, you could say, is all about consequences. So the consequences decide. The consequences are not merely important, but they decide what is the right thing to do. And utilitarianism argues that consequences in terms of utility is the crucial thing. It was developed during the 18th and 19th centuries, but it's highly relevant today because risk-benefit, cost-benefit analysis are all based on utilitarianism. So this is a very important theory today. And for example, achieving herd immunity and saving as many lives as possible would be utilitarian goals or utilitarian aims and values and strategies. And of course, we can all agree that consequences are important, consequences matter, but there's a competing ethical theory or ethical theories that are called deontological theories, and there are duty theories, duty-focused theories and rights-focused theories. But the main idea here is that consequences are not crucial when it comes to what is right and wrong, because sometimes, regardless of the consequences, there are boundaries to what we can do. So they're right and wrong are not decided by the consequences. The duties we have towards other people and the rights we have put boundaries to our actions. So regardless if the consequences would be best if we chose X, perhaps we shouldn't choose X because that goes against our duties and rights. This kind of theory is relevant today too. We of course have human rights, we have legal requirements, and we have other values that relate to rights. And in the case of public health, right to health, right not to be harmed, but also right to autonomy, right to privacy, etc. And there could easily occur conflicts of values and dilemmas within this perspective of this theory as well. The third main ethical theory is virtue ethics. And whereas the first one talked about consequences, the second about duties and rights, virtue ethics argues that it's not just about the isolated actions and decisions, it's about who we should be as people, as a person over a lifetime. So we can develop and we should develop certain virtues. And today we don't talk so much about virtues, but instead we maybe talk about character traits. And these virtues or character traits that we develop through experience and role models help us flourish as human beings. So they're kind of good both to ourselves and to others. And I think that's a relevant theory today as well. I think some of professional ethics is about, for instance, being a good or becoming a good doctor, becoming a good engineer, and it's about how you are and not just what you do in isolated actions. I think also that this is a way we see parenting. We want our children to become kind and empathetic and brave, perhaps, not just that they do the right thing in an isolated situation, right? So I think that is a relevant theory as well. So we have three main ways of thinking without going into details. So you could think that the goal should be to maximize utility, consider the consequences or expected consequences, or you could argue that you should first and foremost act in accordance with duties and rights, regardless of consequences, or do what the virtuous person would do, act virtuously and develop virtues. So this is just a background of ethical theories and perspectives. And the question for us is, how do we apply these ethical theories to risk management and risk communication? Is that possible, and how would you do that? And then, so we talked about the ethical theory, so now we have to talk about risk. What is a risk? We talk about risk a lot in modern society, but it's sometimes not clear exactly what we mean. Sometimes we refer to the unwanted events that may or may not happen. For example, lung cancer is one of the most serious health risks affecting smokers, you could say. And then we would refer to the unwanted event. Sometimes we refer to the cause of the unwanted event, so saying that smoking is the most important health risk. So in the first case, it's lung cancer that is the risk. Second, smoking is the risk. Or third, it's the probability of the unwanted event. So, for example, the risk that a smoker's life will be shortened is about 50%. I'm not sure about the numbers, but it's a way of using the concept of risk in the probability sense. Or a more decision theoretical concept is that the decision is made under known probabilities as opposed to complete uncertainty. So we have different ways of using the concept of risk. And as a philosopher, it's important to first talk about the concepts. Conventional risk management, where we do a risk-benefit analysis, a risk-benefit analysis is used to decide acceptable risk. What is an acceptable risk? How should we choose between different decisions or interventions? Risk-benefit analysis. So that would decide what is an acceptable risk. Sometimes we assume that this is an objective or value neutral method. It's the way we do it. But it is based on utilitarian thinking, the utilitarian perspective, which actually includes, and this is where the difference between healthcare and public health comes in, because we have the population focus, and then a risk to someone can be outweighed by a benefit to someone else. It doesn't matter. So we just put all the risks in one on the one side and the benefits on the other, and we measure it, so to speak. So it's based on this, and maybe this is necessary, but it's important to keep in mind that conventional risk management is based on utilitarianism. So we can see that the regular healthcare setting is governed by an individualistic risk-weighing principle, you could say. So then we have the doctor-patient communication, and the individual patient decides on what is an acceptable risk with a treatment, for instance. Whereas in public health, we're dealing with a collectivist risk-weighing principle, where the government communicates with the public, however that is defined, and the government decides on risk benefits for the whole population using, for instance, statistics. So this is one of the main differences from an ethical perspective. It's also interesting to look at the difference between experts and lay people, and you may all be aware of and use risk perception research, but just to restate the difference, that whereas experts usually conceptualize risk as the statistical expectation value of an unwanted event that may or may not happen, where the focus is the probability multiplied with a negative outcome or harm. So that's the very technical concept of risk. But then, and as I'm sure you're aware, lay people do not decide on acceptable risk in the same way, or don't view risk in the same way. So lay people would more easily accept a known risk versus a new risk, for instance, natural versus artificial. And of course, there's a whole naturalness idea in the vaccination context, but it's a general aspect that many people think is important. And there are all these aspects that have been shown in psychological and behavioral research about lay people's perception of risk. And of course, we sometimes assume that people are in general guided by emotions. And, you know, if you look at the whole vaccination debate, for instance, that some of it is irrational, etc. And some of these aspects may be less, well, not great and problematic, let's say. But some of them are not. And we cannot make conclusions about ethical values, normative values, directly from knowing what people in general think or feel. But some of these aspects are actually normatively important, like my colleague Sabine Ruser in Delft has discussed many times and written about. Fairness and voluntariness, for instance. So fairness in risk-benefit distribution is also normatively important and justifiable. If you are exposed to a risk or you choose it, matters. And if person A gets the benefit, but person B is exposed to the risk, that is a fairness issue. So from many different perspectives, these would be normatively justifiable aspects. So how do we apply ethical theories to problems of risk then? Well, it turns out not to be that easy, as first and foremost, my colleague Sven-Ove Hansson has discussed. Ethical theories deal with well-defined problems. So traditionally, ethics deals with well-defined problems where the consequences are known. But of course, reality is characterized by risk and uncertainty. We know something, we have some knowledge and information about what will happen, but there's also a lot of uncertainty, like in the beginning of the pandemic. How would it develop? We didn't really know a lot. Knew something, but not the whole. We didn't have the whole picture, of course. And trying to apply ethical theory to risk is difficult, because if you deliberately expose someone to harm, that would be a wrongful action, according to most. But if you're exposed to a risk of, for example, radiation or a side effect of a drug or something, the probability is 1 in 10 or 1 in 10,000. Where would you draw the line? When would that risk actually be harm? It's not that easy. So it's more difficult when we are dealing with risks. So if you use the duties and rights-based theories, for instance, you have a duty not to harm anyone. You're only allowed to expose yourself to risk or take risks. But wouldn't a lot of the things that we take for granted today be prohibited then? Driving, chemotherapy, other treatments and interventions, what would actually be allowed if we applied this duty to do no harm generally? So that's very difficult. Virtue ethics is also difficult, but I think it has some relevance, and I will get back to that. But how would a virtuous person deal with risks, or a virtuous government? Which risks would be acceptable? That's not easy either. So we are left with utilitarianism. This is what we use. So expected utility, focus on collective health, and that collective health should be maximized. But then how do we choose health problems? How do we know from a utilitarian perspective which health outcomes, which health problems should we choose to focus on? Which outcomes, and how should we measure and compare? And I know there are some methods to compare QALYs and DALYs and statistical lives, etc. But it's not as straightforward from an ethical perspective as we would have hoped, maybe. So it's difficult even with utilitarianism. And the problem is that if a majority benefits from a treatment, measure, decision, or something like that, and a minority is exposed to risk, that could be considered acceptable from a utilitarian perspective. But there seems to be, it's an ethical challenge still, I think, even though we don't talk about that so much. But we have a lot of examples where the majority benefits, but a minority may be exposed to risks. And how do we even compare these different groups? I had some examples there, but I don't have to get into that. So a core ethical problem here is, how do we reconcile individual rights with the health of the population? So we have individuals and we have the population, and how do we reconcile these? So all of these theories are inadequate. So the traditional conventional ethical theories are not completely adequate to deal with problems of risk management, risk communication. So that's why I think that the concept and notions of moral responsibility is a better way of approaching, or at least an additional approach we can take. So as I said, modern society, it has been described as a preoccupation with risks. We talk about risk, we discuss it all the time. People in general, the media, governments, we talk about risk. And this is a bit different from previous times in history where we always had threats to deal with. But today we conceptualize these threats as risks. And there's an implication or assumption when we use the concept of risks that it actually can be controlled to some extent. It can be managed. And if it can be controlled and managed, then it's natural to see that or think that someone is also responsible to actually control and manage the risk. And so responsibility is key here, and it can be individual responsibility and collective responsibility. And when we're dealing with collective problems, as climate change, environmental problems, antibiotic resistance, and the pandemic, public health in general, it's reasonable to think that governments have a responsibility to solve the problem or minimize the effects, or and so forth. But the actions of individuals taken together contribute to the problem, to a worsening or a solution of the problem. Whereas cancer, for instance, that's one and the same individual that is affected. So smoking, for instance, there's a responsibility for oneself. Of course, it's a lot more complicated than that, but there is a difference between that case and infectious diseases, where you potentially harm others or risk harming others as well. So responsibility for yourself and for others. So collective problems are difficult or challenging. But if we talk about responsibility in this kind of collective problem context, then we have to talk about responsibility. And just like the concept of risk, the concept of responsibility or moral responsibility is complex and involves many different aspects. Is it just about causality? Is it about blameworthiness, capacity, authority, having to give an account? Is it a task responsibility or a role responsibility, or responsibility as a virtue, being a responsible person, taking responsibility? So there are many different concepts or aspects. In my view, it facilitates our thinking of responsibility if we consider it as as a main distinction being between backward-looking responsibility and forward-looking responsibility. So being responsible for something that happened, or actively taking responsibility to solve a problem, for instance. We also have different values in mind when we talk about responsibility. Sometimes it's about fairness. What is the fair distribution of responsibility? And sometimes we are focused on efficacy. Who can solve the problem? How do we solve the problem? So that's just a basic kind of scheme to think about this. So as a philosopher, it's important to try to figure out what we're actually saying, which concepts are we actually using. So if we talk about responsibility for the pandemic, for instance, or for public health, we could actually be saying a lot of things, and different people could be saying different things or referring to different aspects of responsibility. It could be, for instance, a question concerning backward-looking and fairness perspective, and namely, is it fair to hold individuals responsible for not wearing face masks or declining vaccination, etc.? Or it could be a forward-looking fairness perspective. Is it fair to expect individuals to actively take responsibility for the future to prevent spreading? It could be backward-looking efficacy perspective. Is it effective to hold individuals responsible? Does it actually help solve the problem? And is it effective to expect individuals to take responsibility, to hold them responsible and expect them to actively take? So these are actually different questions. So we have to know what we're actually talking about. In my view, and I think time's running out as well, it seems like the responsibility of the governments is so not just the utilitarian minimizing spread, saving lives perspective, but also, as has been clear during the pandemic, it's also about not having too much infringements on other kinds of rights like autonomy, etc. So it's a lot of things that are included in government responsibility here, and also, as I said, trying to take into consideration people's autonomy, while at the same time having the utilitarian collective focus of saving as many lives as possible. So it's a complex situation. So trying to, instead of just trying to balance risks and benefits, trying to balance risk-benefit calculation with all these other values and rights. So it's a tricky situation. But we need, of course, individual responsibility as well. And this is where I think the concept of responsibility as a virtue comes in. We need behavioral changes, and we need to think of it long term. We will have more pandemics, we will have other kinds of public health problems. So I think this is where responsibility as a virtue comes in, because we need to develop and cultivate certain virtues and characters. Maybe, for instance, having a sense of solidarity, a sense of responsibility for other people and for avoiding harm and helping other people. And responsibility as a virtue has been described in a philosophical context as navigating the complexity of relevant values and principles, or responding to a plurality of normative demands. So not just one, but we have several normative demands that we have to navigate. And I think this is applicable to public health, and as it is to environmental problems, for instance. So this is one way of viewing individual responsibility long term as well. Actually, I think, yeah, so it's my time is 11:41, so I should stop there. And I know there's a lot of information, so you don't have to, but I hope you got the sort of big picture of my view on this. Thank you.
Thank you very much, Jessica, for this excellent presentation. I have to thank you as well for, during your talk, at some point I noted down, you said, as philosophers, we need to start from the concepts. And I think it's not just as philosophers, all of us as public health researchers, as public health practitioners, but also everybody needs to start from concepts. And I would like to thank you for giving us, in a very short time, a crash course through the ethical theories and what the ethical questions might be or might have been. So I will start with a question. I wrote it in the chat, but I will also address it right to you. When it comes to moral responsibility as a virtue, is it an individual virtue or a collective attribute? What I'm thinking is, if it's an individual virtue, where does the duty to cultivate moral responsibility in individuals lie? Does it start with the family, or is it a collective attribute in the sense that societies that have the right systems, processes throughout a person's life make sure that these virtues are cultivated early on, so that it becomes a collective attribute because it's more than the sum of its parts. This is what I'm thinking. So I would like to know your thoughts about this. Where does it start? Does it start with the family and parents? Does it continue into school? How do you move forward?
That's one of the most interesting questions. Thank you. It's very interesting, because I think if you go back to virtue ethics as an ethical theory, the context is very important. Maybe more important than with at least utilitarianism. So the context can, the context, the system, society, family can facilitate the development of virtues. And I think that's a very important question. And I actually just wrote a response to someone who had written about structures of virtue. And her idea was that it's mainly in the structure. And one of the things that she argued was that if you take the virtue of empathy, for instance, it's which I think is one of the most important virtues. Also, empathy could be seen as being in the structure, kind of. What was she arguing? That it doesn't matter if you actually feel empathy, but you can be taught by the system, by the context, by society to act empathetically. But in my view, it's, the collective level is very important because it can facilitate individual virtue, but I think it's dangerous to just see virtues on the structural level. So I think we need both. But also, as you were talking about families, that's one of my most recent under review, actually, article about children. And I think you have to start there, because you don't just get to be or expected to be a morally virtuous or person when you turn 18 or 21 or whatever. You have to start early. You have to learn how to be empathetic, having a sense of solidarity, being a responsible person. You have to start early. So I think in public health as environment is one of these issues that we have to talk about at an early age and just continue to talk about. So family and society can facilitate virtues, I think.
Yes, thank you very much. If there are any questions, please write them in the chat, or feel free to raise your hand, and then we can also hear your voice. If there is, Yorgo, I can see a raised hand. So you can go first.
Thank you, Nikos. Following what you said, Jessica, about a research article that is under review, I would like to ask, in terms of research in this field, how can we quantify, how can we measure responsibility at the individual level or the societal level? And is there any way to associate this with the outcomes? And let's take the COVID-19 pandemic. Is there any association between these differences across countries in terms of responsibility with outcomes, or is there any research effort to study this, and how can we do that? Actually, I want to understand more how we can organize research in this field. Thank you very much.
Yeah, that's another very interesting and important question. Of course, I don't have to measure in my discipline, but I know it's important to do that as well. And actually, it's interesting that you mention it, because I wouldn't have thought that you can measure values or traits like responsibility, but I'm actually involved in another project that deals with environmental problems, carbon dioxide emissions. It's a French project, and economists are actually, my colleagues there are French economists, and the idea there is to actually find a way to define and perhaps measure capacity to act. And we have a lot of interesting discussions there, because they too want to try to measure and say that how can we conceptualize capacity to act as a step before responsibility? You see, as the first step, can we actually compare capacity to act? Who has a capacity to act and who doesn't? So trying to sort of discuss that as a first step before involving the moral aspects. So that could be one such, but I think, yeah, it's an important and interesting question, but I don't have an easy answer. But that's what I know, that project, but I don't know if there are other.
Actually, there is no easy answer. As a social epidemiologist, I can add to the conversation that the hardest things to measure are things that are both individual values and virtues, and that are also collective attributes. For example, it doesn't stop there, social responsibility. How do you measure social cohesion? How do you measure social integration? How do you measure all these ideas, these concepts that pretty much are bigger than the sum of their parts. So as quantitative researchers, we might take the approach that we ask people, you know, how, to give an example, how connected they feel with their community or to others, or how empathetic they are. And then you take the traditional approach of, you know, aggregating that to a community level. And the problem is that those two are not the same thing. You're not actually measuring what you should be measuring there. So it is a very difficult, these concepts are very difficult to approach quantitatively. I want to turn our attention to a different issue now, one of transparency. You mentioned in your talk that the countries might have taken a different approach, and you classified them in three main approaches: laissez-faire, or herd immunity, or more strict. In my view, countries more or less took similar approaches in terms of what the measures were, because there wasn't a huge range of them. And what was really different was the degree to whether these measures were legally enforced and monitored, which would be your classification of strictly imposing these measures, or whether it was a call to common sense and civic duty, and whether they were strongly recommended, but to a large extent, countries, one of them Sweden, were relying on people to apply these measures, even if they're not, they were not enforced. So coming from this perspective, this is what I'm thinking. Is it a collective attribute? What are the characteristics of a community, of a people, that would make a government decide, for example, whether, you know, you can rely on the citizens to apply common sense and exercise their apply the measures out of civic duty, and to bring in the concept of transparency, how important is, because very often we've seen, I think Cyprus is an example of such a country, that the concept of transparency was translated in terms of, knowing the daily statistics of COVID cases, of COVID deaths, of what was discussed, who agreed and who disagreed with the measures, who said what, and so on. And that was transparency. But is transparency also related to the values and what is guiding this approach, acknowledging where you're coming from, where the measures are coming from, what is guiding you, what the trade-offs are, what are the ethical considerations that guided this decisions? A very wide question. So,
yeah, but a very good one. And I think that the governments should be transparent, both in terms of scientific evidence, but also about ethical values. And I think even though you can't measure these values that we just said, we need an ethical debate in society, and we have to acknowledge that there are ethical values at stake as well. And I think, I know the Swedish government has been criticized and can be criticized, and etc. in our agencies. But I think one thing that they actually did is that they talked about values to some extent, and about responsibility and solidarity with other people, with vulnerable groups, and so forth. So, which I thought was very interesting compared to previous situations where it hasn't been that. And I don't know what it was like in other countries, but I thought it was interesting how all of a sudden, or as a new development, ethical values were actually mentioned in the debate to some extent. So yeah, I think it's very important to be open about this, and to, yeah, and I have a course in ethics of public health with master students who are very engaged in these topics, and one of them said that well, I mean, we have a lot of other obligations in society, and maybe it's reasonable to think of vaccination, for instance, as an obligation, as a duty, as a responsibility. And yeah, I think that's a very reasonable point to that we talk about these things in terms of responsibility to protect others, etc. So yes, I think transparency in terms of, and just saying that this is a decision that has scientific components, but also ethical values. So I think that could be done to a greater extent in Sweden and probably elsewhere, but there were some kernels there.
thank you very much. Any more questions, or we'll take 2-minute break so that we will move on to the second part of today's
And Nico, we have one more question from the audience. If we want,
I'm sorry, I wasn't looking then. Yeah.
Yes, hello. I was wondering, you mentioned in your presentation that, like, when public health, we should consider mental illness and we should consider mental health. And I was just like wondering and curious, how is public health associated with mental illness? I mean, how can it help, for example, with depression, anxiety, or even like the post-pandemic situation that everyone is going through, especially to young people like myself that have been so affected or even shocked with the whole situation?
Yeah, I think you have a really good point there. That I think you could consider the effects on mental health as an unfortunate but necessary side effect when you focus on minimizing spreads of the disease, or you take that into consideration early on. And I don't know, it's partly an empirical question as well that I'm not suited to answer, how you can affect that or take that into consideration, but I think it's an important aspect that may have been excluded in the beginning, or we didn't think about it because everyone was in a kind of panic and governments too, to minimize spread. But that is one of the effects. So yeah, and I think we have, when it comes to public health, we have intended effects and we have unintended effects. And that's why you need some kind of caution and to consider all the aspects beforehand. But of course, in a pandemic, there's not a lot of time. It's like in the emergency room at the hospital, the ethical analysis in the emergency room cannot be as thorough as the ethical analysis at primary care units, for instance. So, but I can't really answer that question. I think it's partly empirical, maybe. I don't know if any one of you, the other people here.
Well, one thought that comes to mind is the level of interdisciplinarity in the task force, and I'm not entirely sure if anyone has looked at that yet, but maybe future, in the next months, people will be looking at whether that is something that made a difference, if we can even find a way to quantify what the difference means. But I'm thinking in many places, there was a lot of interdisciplinarity in the task force to include social scientists, behavioral scientists, ethicists. In other places, the views were predominantly biomedical, from a biomedical point of view. Perhaps many countries later on realized that there would be all these consequences or unintended side effects, as you mentioned them, and established, Cyprus is an example of such a country, established other committees aside the main advisory committee that will look into the mental health and social aspects of the pandemic to make their decisions, but they were working in parallel. So I think, how do you negotiate these different views into a task force that would look at an issue more holistically? Was perhaps a defining difference between countries' responses, whether it was done from the beginning or somewhere along the way. But at the end of the day, whether it did or did not make a real difference in terms of the response to the pandemic, I'm not sure we can actually give an answer to this. But I do think interdisciplinarity in the task force is probably what might have influenced the approach in the response a country took to some extent. I'm not sure about Sweden, if you can share with us whether the task force was included people from different disciplines, including people like you, to have the ethical perspective, or social and behavioral scientists, or?
It's a very good question. I'm not sure. I'm relatively sure that there were no ethicists close to where the decisions were made, actually. Right. But other than that, I don't know. Yeah, but I think it's a very good point.
Or whether they were more of a token. I know that in Israel, through colleagues, ethicists were included in the task force, for example. Whether at the end of the day it did make, this is what I mean, this is where I'm coming from, whether it did make any difference in terms of the actual response on the ground, I am not that sure. Okay, I think, Urania, if you confirm that there is no more questions or raised hands that I'm not aware of,
yes,
I would like us to move to the second part of today's meeting, because we do have about 45 minutes, and it is limited time for what we have in mind. So thank you, everyone, for being here with us today. As it was said at the beginning, this is the inaugural event of CyEPHA, of the Cyprus Epidemiology and Public Health Association. My name is Nikos Middleton. I will be facilitating this second part. And to make a start, I would like to thank our invited speakers and call them to turn on their cameras. Both Dr. Zigers Paget, Executive Director of EUPHA, and Dr. Nihlén Fahlquist, I'm sure I didn't pronounce the name right, will be joining us for this panel discussion. And we really appreciate it that you're here with us alongside the members of CyEPHA's interim board. It's a large panel, so to provide some structure in this limited time that we have, this is what we have in mind. We divided the panel in 3 groups, and each group will give us their thoughts on one topic around moral responsibility, but also resilient health systems, which is today's theme of the European Public Health Week. So we prepared 3 questions in total. As you will see, each question is on a very wide topic, and in my opinion, quite challenging to address, to the extent that I'm actually glad I'm not on the receiving end. I think we will challenge our panel quite a bit today. So to start, I would like to turn our attention to a different set of actors. And I would like to address the first question to Jessica, Andri, and Alexandros. We've been talking about moral responsibility in the context of public health threats and the COVID pandemic. And we focus on the social responsibility of citizens in the response of the COVID pandemic, but also governments. But I would like to turn our attention to the scientific community. And as we all know, and we all have experienced, there was, alongside the pandemic, there was an infodemic. And there was a constant flow of information, but also misinformation and disinformation, in which case communication from the authorities was crucial in order to maintain public trust. Communication that was timely, that was accurate, that was transparent, including the values, and it was balanced. Often, though, I think the messaging resorted to the deficit model of listen to the expert, trust the science, and so on. But there were so many individual experts appearing daily on our TV screens and other media that it was hard for anyone to differentiate what was evidence, what was opinion, what was values. And this often created conditions of what we call false balance, different viewpoints, but presented as more equal than the evidence allows. And often these viewpoints were not even opposing, but perhaps presented as such by the media. And I think this raised questions about the ethical responsibilities involved in health and science communication. A code of ethics, if you like, for science communicators, for the scientific community, but also journalists alike. So what is the role of professional associations, scientific bodies, academia in counteracting this phenomenon? I would like one of you to go first, either Jessica or Andri or Alexandros.
Should I go first?
Sure.
Yes, please.
Thank you, Nico. Thank you, Jessica. It was a wonderful presentation that touched on many of the topics that we have here on the panel as well. I'd like to pick up from Nikos's mention on the deficit model, because I think that one of the issues is that we tend to view public opposition as stemming from ignorance. So we guide our science communication efforts in filling this deficit in knowledge, hoping that once people understand the scientific facts, they will view the issues like we view them. However, as fundamental as basic science knowledge is, this emphasis on the deficit model does not recognize that, like Jessica mentioned, knowledge is but one factor among many that are likely to guide how individuals reach judgments. And this is even further complicated because of the abundance of competing media and content choices. So especially in health-related states, such as the current pandemic, it's important to also consider the model of public engagement, or the interactive model, which places emphasis on stakeholder participation. And this doesn't mean, like Nigo said, that the view of an expert on a topic carries the same weight as the view of a lay person, but it means that the public becomes part of a community, of an evaluation team that provides feedback, and provides feedback especially on the values, on the societal values, like as Jessica pointed out, are key in defining which approach is better suited for that population, for that society. The one size doesn't fit all approach, like we already talked about, because science shouldn't dictate policy, as we've sometimes seen in this pandemic. It should inform it. So with regards to professional bodies' responsibilities, I think we need to perhaps get better in communicating risk, not just benefit of science, but risk and uncertainty, and getting feedback on what the values of the society are, because it's the values of the society that will determine the acceptable or the reasonable risk, like Jessica so well mentioned before. So unless we are open about the risk and the benefit, we are counterproductive. We erode the public's trust, like Nikos mentioned. And in the end, this is how we open the door to misinformation and disinformation. So I think we need to be honest with ourselves first. And as scientists, we need to also look at our personal moral responsibility and perhaps reel in a little bit our enthusiasm about science and what we need to communicate, and refrain from perhaps feeding into the cycle of hype that the media are only too happy to generate, and be honest to the public about what we know and what we don't know.
Thank you very much.
Comment.
Thank you very much. Who would like to follow with their thoughts on this very wide, indeed, topic?
I could continue. Yeah. Oh, I absolutely agree with all of what you said, Andrea. I think it's it's such a pedagogical challenge we have today to communicate the science, but still be humble, I would say, to the fact that there are also ethical values involved, and people may understand risks in a different way. But I absolutely agree. I also think one of the important aspects is also that we as science communicators talk about things that are within our expertise. That is one thing. I think at least in Sweden we had economists talking about health issues, for instance. So I think that is one of the responsibilities that we could discuss within our professional communities as well. I think also part of it is to, even though you put science communication as the term on your slide,
I think we're losing the connection. Yep, it might come back. Until that happens, let's, Alexandre, would you like to
yes, absolutely.
pick up until we make sure that Jessica's connection is stabilized?
Absolutely. And once Jessica reconnects, I mean, I will pause and then she can continue, of course. So very interesting points from Andrea and from what I've heard at the beginning of Jessica. I mean, my take on this, everyone, I mean, I see another two dimensions that we haven't discussed so far about this issue. I think, first of all, mistrust is a very major player in all of this. And when I say mistrust, I mainly refer to mistrust of the public towards the scientific community, which unfortunately, at least in this pandemic, is seen as part of a general plot, kind of a system who is trying to, enforce bad ideas based on, some kind of agenda. So we have a huge obstacle there to overcome as scientific community, and it's something that I believe we are kind of aware of, but it hasn't been officially, quantified in a lot of countries, including ours. And it's something that definitely needs to be addressed. It's a game that we have the duty as scientists to try to, win back the trust of the public, of people. Personally, I'm not sure why and how we lost that trust. And it's not universal, of course. Surely there is a big chunk of the society that still trusts scientists and trust the information we pass to the people. But there is also, as we all know, a very large chunk of the society that does not trust what we are saying as scientists, or maybe chooses who are the scientists that we trust. And the question for us, I mean, the majority of us here are, at least in the panel, experts in public health. Another question is, who are the people that have the truth and have the knowledge and the skills and the expertise to talk about issues relevant, let's say, to the pandemic? Is it us? Is it also doctors? Is it nurses as well? Is it health economists? So who is, who is responsible for providing valid, information? It's another, issue that we should all consider. And maybe closing my thoughts with another dimension that is kind of relevant, in my opinion, is whether there is a kind of universal truth about different aspects of the pandemic, from the very basics of how it started, what is it all about, how it is managed, what about vaccination? Is there a universal truth, and who are the people? I'm thinking now, doing the devil's advocate in terms of the public. Who are you guys, Alexandros, Nikos, Yorgos, Urania, to tell us that you own the truth and you have the truth and you will pass that to us? I mean, my take on it is that, and indeed, what you mentioned, Nico, before, the role of journalism is really nice and attractive and picky for the media to show that, well, you know what, it's two truths out there, and it's the opponents of one truth and the other, and we don't really know which is the actual truth. And maybe there isn't one truth, maybe there are several ones. I mean, as a scientist, I have to say that this, concept of not having a universal truth might hold for several things in life. And I mean, surely psychologists would agree in that it's kind of subjective. Your truth, the other person's truth might be a bit different, but for science, we need to clarify, first of all, and agree between us that there are specific things that there is one truth, okay? And there is a way to, identify this one truth, and the way is through research. And sometimes, or usually in life is, not black or white, it's kind of gray, but sometimes in science, it is black or white. We have the responsibility to pass that on and communicate it to the public. And what I mean, and I will just close with that, a way of thinking this, let's say, do vaccines work or do they not work? Do vaccines do more harm than good? So for me, these are questions that are kind of, black or white. So do vaccines work? There is an answer there, and there is a definite answer. Do they do more good than harm? There is also an answer there, and it's again black or white. So I think as scientists, we have the obligation to try to communicate this. And of course, I will come back to where I started and say, people might say, and who are you guys to tell us that this is the truth? As I said, we can say answer to that we are the people who can, read research, can understand, can comprehend research, and the facts in science are coming from research. They are not coming from what Alexandros thinks or hypothesizes or what Urania thinks. They are coming from empirical findings in research. So I think this is something important to have in mind. It might sound provocative to some, but I think we need to be clear about it, that research is giving us evidence, and most of the time, not always, most of the time, that is conclusive, and we can, communicate these conclusions. So, I mean, this is my take on it, and surely we can talk a lot about it also later on.
Yeah, thank you very much, Alexandra. It is indeed a very wide topic, and there's no way we can cover all aspects of it. Jessica is back though. So Jessica, before I move on to the next question, if you want, because we lost you for, at some point, if you have something to you wanted to add, otherwise I'll move on because the time is ticking.
Yeah, thank you. So I forgot what I was saying before, but I just wanted to say that I agree with what was just said, that it's a challenge. It's about acknowledging that there are both science parts and value parts, but we have to clarify what is what. And I think part of the challenge is to talk about scientific method in a very pedagogical way. And so we don't just inform people about facts, but we talk about how those facts have been achieved. So, but I agree with what you just said. Thank you.
Thank you very much. So I will move on. I dedicated about 15 minutes to each of the three groups. So I would like to address the second topic. It's not really a question, is again an enormous topic to Dineke and Urania. So my introduction here is, we all know that health systems and healthcare workers came under extreme pressure to care for COVID patients while continuing to serve the community, provide care for all other patients. And of course, there were disruptions in healthcare provision, and unwanted consequences were not avoided. Flattening the curve and protecting the healthcare system from reaching capacity became a key message in several public health communication campaigns across the world. And while intended as a call for the community to participate in this collective effort, there were plenty of voices about government responsibilities to expand capacity in ICU, beds, ventilators, and so on. And I provide a quote here, which I would like to read because it refers to resilience. During a crisis, a resilient health system is able to effectively adapt in response to a dynamic situation. But resilience cannot be achieved solely through unidirectional top-down approaches by governments and other entities. Resilience requires community engagement as much as regulations and hospital capacity. So I'm thinking, why was it so challenging to get across the message that healthcare resources, human, financial, technological, are finite and need to be utilized effectively, prioritized, and rationed, so that through community engagement in this collective effort?
Thank you very much for the question. I'll go first, Urania, if that's okay with you.
Yes, that's fine.
Perfect. Yeah, I think that, I mean, everybody's talking about resilient health systems and, like network, you have to really include the whole of the population. You have to work with other countries to make sure that what you want. And what we always hear is that you have to build back better. But I think you have to innovate. So you have to see what worked in the past and what did not work in the past. And like one example could be the NHS system in the UK. You also need to be very attentive towards inequalities and inequity. I mean, during the COVID pandemic, the health inequalities increased enormously. So it's a huge problem. And let's try, if we build back, let's try to include that as well. There was also mention of already with the previous speakers about learning from the evidence. And that does include how can we present the evidence in a format and in a way that it's understandable by the general population. Because if you just say, these are my methods, these are the conclusions, without saying what does it mean for policy or what does it mean for the population, it's not going to have the same impact as the fake news, for instance. And you also need to have a learned and well-trained, well-financed health workforce, and that is extremely important. What we've seen in the during COVID is that a lot of healthcare workers actually got a burnout. A lot of the students basically stopped their nursing education and said, listen, this is so intrusive in my personal life if I have to care for patients with COVID. So they stopped. So it's a big problem, and it has been a problem for years. So we really need to make sure that we build back better, bolder, and broader. Thank you.
Thank you very much.
Shall I go next? Okay, I think, Nikos, I mean, your question on rationing and on prioritizing health resources, I think it's not something that it's new. I mean, people have been exposed to these concepts before, and I think it has always been challenging for the public to understand these concepts, because people think about their individual rights to health, they think about their individual rights to life in general, but they don't think of collective health rights, as Jessica said, they're thinking about only about their individual rights. And this is where we need to build the responsibility aspects that Jessica was describing in her presentation. And that means that we need to help people build a higher sense of solidarity and also a higher sense of trust in what the governments are doing. And I'll go back to what the other people have said before for the other topic, that in order to build trust, of course, we need transparency and we need inclusiveness. And these are the two main aspects that we will need to invest on if we want to build the values that Jessica was describing in her talk. If we are transparent, if we are inclusive, and we involve the community in our decisions, then they're more likely to understand difficult concepts like the concepts of rationing, like the concepts of prioritizing health needs, so that they can help. Because as we know, and Dine very rightly said, it wasn't just only about having the resources for people to get treated at the hospital, but it was also about respecting the fact that those healthcare workers were getting burnout. And I think people didn't even realize that it wasn't just the government expanding the health services, it was about not having the resources and not sticking to the recommendations, was meaning that the resources were getting less and less rather than getting more and more. So the kind of my end, I would like to end this up by saying that if we want people to understand difficult concepts like rationing and prioritization, so that we can help our healthcare systems to be resilient, we need to cultivate solidarity in people and trust. And cultivating trust means that we need to be transparent and inclusive and including people in our decisions.
Thank you very much. I don't know if someone else from the panel wants to add anything on this topic. Otherwise, I will move on to the next, and perhaps we'll have more time for discussion on final thoughts, because I'm very well aware of the time. So let's move on to the third group. So I will address the question to Yorgos and Dimitris now. So black or white, is it always that clear? Health versus the economy was one of the dichotomies, in my opinion, false dichotomy, in the public understanding of the COVID response. According to this quote, saving lives versus saving livelihoods. Just to give an example, in Cyprus, like there was opposition to lockdowns and school closures, There was also opposition to schools reopening and the test to stay measure. The main argument being that the measure was economically motivated while putting lives of teachers, of children, of families at risk. I think this is just an example of how important it is to communicate effectively and transparently what the goal of the strategy is, what the necessary trade-offs are that need to be made, the just sharing of the burden, as Jessica was referring to, avoiding what was termed the intergenerational transfer of the burden to children and families. Could this black or white understanding that we experienced during the pandemic, people thinking that it was a choice between health or economy, could it also indicate a deeper issue, perhaps a very restrictive, a very medicalized view of health, or a problematic, perhaps, understanding of the wider determinants of health, the overall dimensions of public health? Your thoughts, please.
Thank you, Nikos. Can I start first, Dimitri?
Yes, of course, yes.
Okay, thank you. Nico, this is a great point and comment, let's say, raised here. And as a matter of fact, I remember it was September after the first pandemic wave, the summer of the first pandemic wave, and we were together discussing about how to set up the association. And we had this particular discussion about risk communication and these dilemmas, these black or white questions in the public from the journalist. And you said something, and you are absolutely right, that we forget that there is also a gray color. It's not only black or white. I believe that seldom in life we face dichotomies. Perhaps the only dichotomy is that we're gonna live or die in the next year. For the rest, I think there are multiple factors involved, even in the medical profession. Disease etiology, it's not only biological. There are also economic and social determinants of health, as we know. And let's think more practical. Let's take an example of a person who comes from a minority group in the US. Is he more likely to get COVID-19 because of biological factors? Perhaps he is, but there are also other issues. That person commutes every day in a crowded subway car. If she works at the service is a factor. She has multiple contacts per day, and she returns home to an apartment which is also crowded and multi-generational. So obviously here, there is not a simple answer. Yes, she's more likely to get COVID because of biological susceptibility. Multiple factors are involved, and also for interventions as well. There is not only one intervention that works, and we've learned that for COVID-19 as well. There are vaccines, there are masks, testing, physical distancing, and it is the combination of these factors that gives maximum effectiveness. And the dichotomy between health and economy, I think it is wrong, because these two are intertwined, as you said. If, for example, we restrict movement to reduce transmission of COVID-19, this will affect eventually the economy. But the economy is also important to maintaining health infrastructure and services. And if it is seriously impaired, even the basics could be affected, like accommodation or even food. But on the other hand, if you let the the economy functioning without any public health measure during an emergency like COVID-19, then people will become sick, many people will lose their lives, and eventually the social fabric and economical productivity will be affected. So the question is, what should we do? I believe first that we need a midterm and long-term strategy to educate people on these issues, to understand the risk, to understand scientific reasoning, to discuss about all the ethical parameters we have already been discussing here. And beyond that, in the short term, because public health emergencies do not end, I think that the first thing we should do when we plan intervention is to involve the community, schools, at work, people. Let's say if we want to intervene at schools, the community, the school community should be involved. Teachers, students, parents. It's not reasonable, for example, for a committee, and I was a member of the committee in Cyprus, to discuss at a higher level without bringing in the people that are going to be affected by these measures. And of course, the advantages, the disadvantages, the pros and cons of every decision should be presented and discussed, because there are trade-offs. Okay, you win in one aspect and perhaps you lose something from the other aspect, but we have to know what we win, what we lose, and then based on that we take the decision. And finally, this decision process should be transparent. I think that we should work in this respect, because, as I said, public health emergencies are here and will be with us in the future. So we certainly should improve the way we deal with these issues.
Thank you very much, Yorgo. Let's move on to Dimitris's contribution.
Yes, thank you, Nico. I think Yorgos covered the topic very well. And I would also like to add some possible causes of this false dichotomy. And it was noticed that in this pandemic, the global community was not used to seeing rapidly emerging science in front of them, and they were not used on changing policy or changing response to pandemic, and therefore has been desperate for immediate and ambiguous answers like black and vs white, that also mentioned before by Alexandros. However, unfortunately, this was a ground for the development of false dichotomy, COVID-19 false dichotomy. And there were several COVID-19 false dichotomy, and the one you have already mentioned, which is health vs economic dichotomy. And indeed, it has been said that the health and the economy are on opposite poles, but we know that this is not true. And we know this historically, that they are interrelated, health and economy. And I think this has been seen also in this pandemic, where public health and economic experts agree that supporting workers and business financially is key to tackling this pandemic. And on the other side, sensible public health strategies that reduce the spread of the virus in the community reduce the health and economic harms of the pandemic. Seen that appropriate public health strategy that reduce SARS transmission, also safeguard the economy, since the toll of widespread illness in workers can lead to disability and death. And also, aggregated data have shown that many countries that suffer severe economic hardship perform worse in protecting their population health from COVID-19 over the past month. So there is not such dichotomy, health vs economy. They are interrelated. And what is the action I would like to Yorgos actions that referred before? One action that it seems that is necessary is that there is a need for a meaningful public health communication and science-informed policy that recognize the shades of gray that is also mentioned before. The uncertainties, recognize the local context and the social determinants of health. Because this was the position of this specific topic.
Thank you very much, Dimitri. Keep looking at the time. We have about 5-7 more minutes. So now I would like to open the floor to all the panelists if they want to add any last thoughts. It doesn't have to be related to what the question that was addressed to you. Any final thoughts, lessons learned, what can we do better? I think everybody's reluctant to go first. Yeah,
I think
please.
I can go first if you want to. I mean, from Jessica's discussion and presentation, and I think from all the positions that we've heard during this panel, I think it becomes evident that the way forward is for us to develop moral values in our populations and try to develop those behaviors, those traits that will enable our societies to have more solidarity. And so that's from the aspect of the population, but of course, you know, these specific traits, everybody has responsibility in trying to develop them, from families, from schools, from governments, and it's important if these are done early in life, as Jessica mentioned. If we start from the children and we try to get them to develop those traits that will enable us to have more morally responsible individuals that will be better fitted to handle public health crises that will emerge in the future. And I think the other thing that I wanted to say is that the other strong message from me from all these discussions is that governments need to become transparent in their decisions, and also they need so that they build trust in the populations, and they need to be inclusive to communities, so that when decisions are taken, those who are affected by the decisions are part of the decision-making process. So these are the take-home messages from this discussion from my end.
Thank you very much, Urania. I don't know if somebody else wants to add some thoughts. I can go next and add some thoughts. And lessons learned. I think it was said earlier that this was a fast-pacing situation, a flow of information from all over the place, and really how the response, what the response would be, to a large extent, I think, depended on preparedness. But the question really was anyone really that prepared? Perhaps not. Some final thoughts from me is that in terms of the community engagement, I think communication is key. and communication that was transparent in the sense that there is always going to be trade-offs. Any dichotomy in terms of we're protecting, the measures are needed because we're protecting lives, you know, that would affect a lot of other aspects of a normal running of society, economy, and so on. But the trade-offs would always be there, and I think it wasn't communicated very well that you cannot have one without the other. It's not a matter of maximizing one while really risking the other aspects of society stakeholders. It was said earlier that we were talking about how inclusive the approach was. I think a whole of government approach, an intersectoral approach, where the stakeholders and the community leaders were a part of these discussions, perhaps would have made a difference in the sense that there wouldn't, the measures wouldn't have been met with the opposition from the side of the community, feel that there was threatening, but rather be part of this collective effort. I guess it's easier, though, this is my concluding thought, it's easier to think of those things in retrospect than while there is a fast-pacing situation. And when these systems are not in place from the beginning, it becomes 10 times more challenging if they're not the default. You know, a whole of government approach, understanding of the social determinants of health, it becomes a lot more challenging to do it in an emergency situation. Any last thoughts from anyone in the panel before I or the sorry, Andrew. Yes, sure.
I think it was a very helpful discussion. I think the pandemic was a very steep learning curve for all of us in many different aspects. And I think we do need to look at this in a pedagogical way, in an educational way. What can we learn? How we can move forward? What can we change and adapt? Because like Yorgo said, the next one is probably right around the corner. I think it's important to have the discussions. And I think one of the aims of this society, one of the reasons we studied it, is so that we can bring the discussions that we had all throughout the past 2 years amongst ourselves, to open them up to more people, to the community, so that we can all together learn and adapt and become more resilient. And to conclude, I think we as scientists need to also recognize that the best social and health responses will not come from science alone. And we need to open our minds to all the different factors, including demographics, the capacities of the healthcare system, the values of the community, the legislative system, so that we can be better prepared and engage everyone better for the, hopefully not very soon, next one.
Thank you very much, Andrew. I think that is a good point and a good message to end today's meeting. Indeed, it's true that, yes, Yorgo, you want to add something?
Yes, very, very short point. If I am allowed, if there is time, 1 minute, less than 1 minute.
Sure.
Okay. I think the most important thing that mentioned by you and Andri is that there is no time for complacency. Of course, we should think in retrospect what we did, but the emergencies perhaps will be increased in the future for various reasons. And I think there is something else that perhaps this is a lesson I've learned, and perhaps a lesson for all, in quotes, experts that participated in committees, that it is very important to think like a person who is outside the committee, because I realized that when, for example, I was visiting my home country, Greece, and I was looking and attending the decisions of the committee here, so thinking like a citizen. This is very, very important for people who advise the policy makers to think not only in a sterilized scientific environment, but also to take into account the needs, the voices of the people around them, to think like common citizens.
Absolutely. That is also a nice message to end today's meeting. And I'd say in coming from a country, a setting where citizen participation in decision-making is fairly new, very challenging, is the way to go forward in public health as well, so that the citizen's perspective is actually represented in the decision making. Thank you very much. I'm very aware of the time. We are a little bit over the time we announced, so people might have made arrangements. I would like to thank everyone for being here today. It's such an honor for so many people joining the inaugural event of the Cyprus Epidemiology and Public Health Association. I see there was some questions in the chat about how you can become a member and who can become a member. As Yorgos Nikolopoulos, the president of the association, said at the beginning, we are at the final stage of the preparation of the necessary preparation, and an announcement will follow for interested people that are interested to join the association in the next few weeks. I would like to thank Dr. Dineke Ziekert-Paget, Executive Director of EUPHA, for being here with us today and for being so supportive of the first steps of CyEPHA. The very most recent member of EUPHA, and of course I would like to thank Dr. Jessica Nihlén Fahlquist for accepting our invitation to deliver the main talk of this session, and for helping us take a step back and think of what we all went through the last 2 years, but from a more conceptual point of view. And we can all start negotiating in our own heads how we balance the scientific evidence, what we know, what we didn't know, the uncertainties that are still out there, together with the values, individual values and collective values that were guiding and will be guiding in the future this public health crisis and all future public health risks that we have to negotiate in our daily lives. Thank you very much, everybody, for being here, and please stay tuned for our next events. Thank you very much.